so happy that Keith Thompson found time today, and so happy about this joint venture with Telemed and with Telemedicals. And we are going to talk about telehealth and daily practice today. Nice to have you here, Keith. Thank you so much for your time.
Ina, thanks so much. I am super excited about this. As I said on LinkedIn, wonderful opportunity to give a global perspective. And I think just as our systems are siloed, I think sometimes in countries we're siloed, not really aware of what's going on in other parts of the world. So both primary care providers, a kindred spirit, since I kept to you on day one talking about this. So absolutely chatting about the myths of telemedicine and virtual care. Thanks so much. This is great.
Yes, I would just say let's jump in and let's start with a very hot topic, and you can read it all everywhere on internet. It's about diagnostics on video conference. So maybe you can tell us about your experience and how do you deal with that in your daily practice?
Yeah, certainly I believe here in Canada, one of the struggles with adoption pre-COVID, as you know, was the worry about what is standard of care and will I be judged as a physician with a face-to-face encounter being that gold standard. COVID hit and kind of ad hoc, we were doing what we could to survive. The major platforms, telephone, interestingly, because it simplifies the workflow. But in the diagnostics, I still hear from colleagues, how do you diagnose a condition, by telephone or by video? And if I might just give a little bit about the verbiage, you may have seen Digital Health Canada released a lexicon on virtual care. And really, virtual care is the global picture, right? Underneath that, telemedicine, telehealth would be the subset. So I guess in today's conversation, we're kind of focusing on, telehealth, telemedicine, those clinical encounters with patients, and how do you make a diagnosis? So it really, from my perspective, I think and probably likewise, I'm sure you're dealing with those patients we have a relationship with. And we know that that's where this technology works best. We know the history. They've been under our care for 20 plus years. So the simple things like a urinary tract infection, or perhaps some describing a rash, a shingles or zoster, it doesn't take a lot, right, to know just by the history alone, what it is that we're dealing with. So, we can start from the lower lying fruit and say, yeah, I know the person, I feel comfortable. What is the risk? And curious your perspective on this as well, right?
Same here. This is the advantage of being a family doctor or a GP, because you have a very strong relationship with your patient. And of course, with skin lesions, it's a little bit more easier because you can show them on the video or you can send a picture. But what about strep angina? Many colleagues ask me, how do I diagnose this? How do you deal with that?
Yeah, it's interesting. I'll be honest, like during COVID, again, I was kind of in survival mode, right? So again, this is a patient that I have a trusting relationship with. And I would always add in that disclaimer. I would say, look, I don't want to risk bringing you here to the office. Best practice may be to treat empirically with a swab, all right? But we don't have that opportunity right now. And so here's what I'm going to do. I'm going to do a therapeutic trial. If this doesn't work, next step might be. And the patient fully understands the risk and benefits of that type of encounter. And we may be able to get, if we're lucky with the video, get a look in the throat. Do we see exudate, redness? Yeah, right? Yeah.
Yeah, so yes, basically I was thinking about this question, and because, I dealt with some guidelines how to diagnose things for World Health Organization. And, the basic thing about strep angina would be performing the center score. So you have this 3 points or 4 points, or you have 6 points for modified Isaac score. But the thing is, it always asks for tonsillar exudate. So you have to look into the throat somehow. Then you have an estimation how likely the patient is going to have strep or not. So it's tricky, but you can do that because you ask other things as well. So you kind of step by step, you elevate your confidence of of the right diagnosis. So I think we have to go back from our very lab and very lab heavy diagnostics and go back to our clinical diagnostic, even though we cannot meet in person. But I think this is the core of this. Like there are maybe two pillars: our very strong relationship with the patients, and like the clinical diagnostics without all the tech, without lab, without anything, but just asking, evaluating, maybe asking it a little bit more differently, and the same question but in a different way or something like this.
It's interesting. I said that, COVID was that agnostic platform that allows us to innovate in so many ways. It allows us to innovate in the diagnostic side as well. And when you think about it, just as when a patient loses their sight or sense of taste or hearing, those other senses improve. And I think in that clinical encounter, the same thing, we're relying much more on that clinical history and, how the patient is feeling and sounding and so many aspects that become much more important, right, in helping us make that diagnosis. And I think COVID has shown us too really how much we can do without hands-on.